I'm Simon Sue. I'm a nephrologist here at the university, and I'm going to talk all about vascular calcifications and clinical trials today. Um, so this talk is broken down roughly into three parts. We'll cover background. We'll take a little detour, talk about surrogate endpoints in cardiovascular disease trials, and then I will summarize all or most of the randomized clinical trials of therapeutic approaches to treating vascular calcification progression in kidney disease. And so this is a refresher for something all of us already know, which is that cardiovascular disease is the #1 killer of patients with CKD and on dialysis. And this is data from a US registry of over 40,000 patients with non-dialysis CKD. And you can see cardiovascular disease responsible for 35% of deaths, and most of these are from CAD or, ischemic heart disease. And because the risk of dying from CVD is higher than progressing to each subsequent stage of CKD, we're not surprised at all that CKD prevalence is the highest in patients with end-stage kidney disease. So this is the latest data from USRDS. Basically, you can see 75% of people on dialysis have any form of cardiovascular disease, with 50% approaching heart failure approaching 50%. And so accelerated vascular calcification has long been hypothesized as a mediator between CKD and CVD, and is a main reason why we're developed and trying to develop new treatments to delay or slow its progression. This study was published over 20 years ago in the New England Journal of Medicine. And I like it because it illustrates some fundamentals about what we understand about vascular calcification in this population. So there were 39 young adults with end-stage kidney disease, so ages 7 to 30, and they all received coronary artery CT scans, and their results were compared with 60 young adults without kidney disease. And so unsurprisingly, most of the young adults without kidney disease did not have any coronary artery calcifications, while nearly all between the ages of 20 and 30 with end-stage kidney disease had evidence of calcification, and that the longer the duration of dialysis, the higher odds that you had of having calcifications. 10 of these adults on dialysis and baseline calcifications had a follow-up CT, and you can see their calcification score doubled over in just 20 months. So mean was like 125 and doubled to almost 250. And so the main takeaways from this paper are threefold for me. So that CKD, end-stage kidney disease, something about it, makes it a risk factor for vascular calcification, and that this vascular calcification is accelerated in people with kidney disease, and that there is a kind of a dose-response relationship between the duration of dialysis, could it be the exposure to the uremic milieu, what have you, but there's an association between that and the severity of the vascular calcification. So what is vascular calcification? They're mostly calcium salts, largely calcium phosphate. It's also known as hydroxyapatite, that really form in the arteries. And I can't talk about vascular calcification without saying that, there's kind of two flavors, calcification in the intima and the media. And both have different pathogenesis and risk factors. And so intimal calcification we think of as primarily inflammation driven. And so your risk factors are your traditional atherosclerotic risk factors, dyslipidemia, diabetes, hypertension, smoking. And the tissue effect you have that I try to illustrate in this cartoon here is you get plaque with lipids and, atherosclerosis inside. And the main effect is plaque instability and vessel occlusion. And so your outcomes logically are things like acute MI, stroke, peripheral vascular disease. And the prevailing thought is that CKD doesn't necessarily incite intimal calcification, but rather accelerates atherosclerotic lesions that are already present, and that this is in general a slower process. And contrast that with intima medial calcification, which we think is mostly mineral metabolism driven, and so CKD is a main risk factor. And so I try to illustrate in the cartoon here, the gray area being the intima, with the calcifications kind of in here. And the tissue effect here is a little bit different. What you have instead is increased vascular stiffness. You can also think of it as reduced vascular compliance. And because of this, your outcomes are a little bit different. So things like left ventricular hypertrophy and heart failure. This is one of several studies that provides a mechanistic basis for vascular calcification causing hemodynamic changes that may lead to things like heart failure. So there were 134 participants on dialysis and CKD4. And they all had superficial femoral artery calcification scores measured on CT and some pulse wave analyses to measure hemodynamic variables. And so you have the tertiles of calcification here. And what you can see is that the pulse wave velocity significantly increases with the amount of calcification in the SFA. Pulse wave velocity, real quick, it's a measure of arterial stiffness. So you put an ultrasound on and you measure the speed at which a pressure wave is transmitted down a blood vessel, and it's faster with stiffer vessels, so higher is bad. And all the way at the bottom here, even though it ended up not being statistically significant, you can see that there is a trend with dialysis vintage and the degree of calcification. And so altogether, work like this have shown that the hemodynamic consequences of vascular calcification in CKD include increased arterial stiffness, increased pulse pressure, and increased ventricular afterload. And I won't go into this in too much detail, but I want to bring up that for various reasons, kidney disease is thought to be a condition of imbalance between promoters of medial calcification, which include things like calcium and phosphate, and inhibitors of vascular calcification, some of which I will talk later, including things like magnesium, pyrophosphate, and this matrix GLA protein. And understanding kind of the pathophysiology of vascular calcification is pretty key in how we develop and continue to develop treatments for vascular calcification in this population. So before I get to all the actual trials, I want to take a little detour and talk about surrogate endpoints and CVD, because in doing this work, I found myself asking, well, so how good is vascular calcification as a surrogate endpoint for cardiovascular disease events? And just a quick review. So clinical endpoints, they are outcomes in trials that directly reflect how a participant feels, functions, or survives. So things like death, MI, hospitalization rate, cancer recurrence, quality of life, and functional status. Contrast that to surrogate endpoints or surrogate outcomes are basically everything else that you measure. And these include measurements of vascular calcification, including coronary artery calcium scores, calcification scores at other vascular sites, pulse wave velocity. So a bunch of labs, measurements, and imaging are all surrogate endpoints. And so what makes a good surrogate endpoint and why do we even use them? So there's two kind of broad principles for successful surrogate endpoints. One is that, it has to be biologically plausible. So you have to have studies that show a direct association between the disease mechanism, that surrogate endpoint, and the clinical outcome that you're trying to measure. And also importantly, it has to have some kind of prognostic factor. And so if you have a change that's induced by a treatment on that surrogate endpoint, it should reflect meaningfully on the clinical outcome, changes in the clinical outcome that you're trying to replace. So advantages of surrogate endpoint, because we're able to measure biomarkers or image everyone in a trial sample, you're going to have higher power, and you don't have to wait for someone to, say, develop that myocardial infarction, and so your trial duration can be shorter. And this may potentially lead to faster access to treatments and altogether lowers the cost of conducting such clinical trials. So these are some of the main advantages. And so without going too much into the weeds, I'll just say that measures of vascular calcification, in particular coronary artery calcium scores, are quite strongly associated with cardiovascular events, so they're pretty good. So what really makes interpreting vascular calcification trials challenging, and why should we exercise care when we interpret them? These are principles that kind of broadly can be applied to other trials as well, but I'll give you a couple scenarios. So in scenario A, your surrogate endpoint, even though it might be strongly associated with your clinical outcome, is not in the causal pathway between your disease and that outcome. And so your treatment may be shown to have an effect on that surrogate endpoint, but when you actually conduct trials with clinical outcome, there's no effect. In scenarios B and C, they occur when there are multiple pathways between a disease and a clinical outcome. And so focusing on B here, if your treatment only affects a pathway through the surrogate endpoint, you can get, a false positive. Kind of similar to A, where, your surrogate endpoint improves, but it has no effect on the clinical outcome. One example I can give is a trial called PROMISE, where they studied milrinone, and they found that milrinone increased your EF over a certain time period, which was pretty promising. But when they conducted long-term, large-scale clinical outcome trials, long-term milrinone had no effect on mortality. And it's probably because, in the disease process between cardiovascular disease and death, EF is probably just one pathophysiological pathway, and there are other pathways that are affected. And so that's an example of B at play. C, you can probably tell, is kind of the opposite, where you think the treatment you're giving is affecting your surrogate endpoint, but it's not. It's affecting another pathway. And so if you just study the surrogate endpoint in a trial, you might get what we consider a false negative. And still, there's a scenario D. So imagine in a treatment that influences all disease pathways, but you can have unanticipated off-target effects on your clinical outcome that's not captured by our surrogate endpoint. And a good example of this is ESA use in patients on dialysis. And so we've known for a while that higher hemoglobin is associated with greater survival. And that when you give ESAs, it increases your hemoglobin, so it should affect all of the, pathogenic pathways. And so we got really excited and say, okay, we're going to give ESAs to really raise hemoglobin in everyone. But when we actually did outcome trials, there was this unanticipated off-target effect of increased thrombosis, right? And that increased stroke risk and mortality, such that, we don't give ESAs to raise hemoglobins to normal. And so all of this really complicates the interpretation of vascular calcification trials. So with that said, we're going to go kind of A to Z through trials of treatments that you're familiar with and end with more investigational approaches. And so starting with phosphate binders. So trials of phosphate binders come in two flavors, right? So calcium versus non-calcium, and then there's binder versus no binders. So one of the first calcium versus non-calcium trials was CARE2 by Glenn Chertow. So over a 12-month period, Glenn and colleagues found that calcium binders had greater progression of coronary artery and aortic calcification scores compared with sevelamer. In the 10-year period since that was published, there were many other randomized trials, and a meta-analysis also favored non-calcium binders. So there's a 22% reduction of all-cause mortality with non-calcium binders and calcium. More recently is a Japanese study called Landmark. Well-conducted study, large, to 2,000 patients on dialysis, followed over a median of 3.2 years. And they found no difference between using calcium carbonate versus lanthanum in reducing calcification. But the takeaway I'll leave you with is that this was a low-risk population with low number of events that probably does not apply to our American patients. For one, the entry criteria, one of them is that PTH is less than 240. And the event rate in this population was 4.3 to 4.8 per 100 person years, which is, think about 4 to 5 times lower than what we see here in the States. So broadly, the take home is if you're going to use binders, the evidence suggests using non-calcium compared with calcium, which is, I think, something that most of us are doing at this point. So comparing binders with no binders, there's one trial that's completed and one going. So Improve CKD looked at non-dialysis CKD 3B and 4 over about a 2-year period. And so they found that between binding and no binding, there's no difference in surrogate measures, vascular calcification, so pulse wave velocity, imaging evidence of aortic calcification, and some serum studies. And I'll just note that at baseline, the phosphorus in this group was already at goal per KDIGO guidelines, so that's just something to keep in mind. Many of you probably know that the HILO trial was unfortunately disbanded because of low recruitment, but there is an ongoing trial called Phosphate that seems very promising. And so this is a study of patients on dialysis and will be randomized to either intensive serum phosphate reduction versus a control group that's more liberal. And so the idea is that so everyone in this study has to be at least on one binder, and the control people will have all their binders discontinued and added back only if the serum phosphorus exceeds 7.7. And they are looking at a composite of clinical outcomes, which is great. And so hopefully this will settle the debate with regards to using binders or not. Moving on to calcimimetics, I think most of us are familiar with this. The two main studies here are Advance and Evolve. So the Advance trial was, again, a one-year study, patients on dialysis. And so what they compared was, okay, you're going to reach a target PTH of less than 300. Participants were randomized to either cinacalcet with low-dose activated vitamin D compared with using just activated vitamin D titrated to this PTH goal. And they found that the use of cinacalcet lowered coronary artery calcification progression scores. Evolve, we're all familiar with, large trial showing no reduction in death or cardiovascular disease events with cinacalcet versus placebo. But interpretation of this trial was complicated by baseline age imbalance. So the cinacalcet group was by pure chance a year older than the control. And there are high rates of dropout and drop-in. So the cinacalcet people did not tolerate cinacalcet over this 5-year period, whereas placebo people started taking non-study cinacalcet. So we still continue to use it because of this complicated interpretation of this trial. And then there is the depth study. It's a quick plug for my trial called De-emphasize PTH that's currently ongoing. It's a trial of dialysis. And again, we're randomizing people to an intervention of a more liberal PTH threshold where we just use low-dose calcitriol and adding on cinacalcet if the PTH is over 800, compared with the NKC usual care algorithm that's a more tight PTH range. And so the outcomes that we're looking at are FGF23, and then a serum measure of calcification called the serum calcification propensity, among other biomarkers. And so we're about halfway done recruiting, and it's possible by next grand rounds, I might have some exciting data, we hope. So moving on to sodium thiosulfate. So we think that sodium thiosulfate chelates calcium deposits into soluble complexes. And there are studies of sodium thiosulfate just indiscriminately for vascular calcification and not just calciphylaxis. And these are the main 6 of them. I'll start off with just some limitations. So you can tell that the ends in general, are pretty low. To qualify, most of these studies require that you had a CT scan showing at least a minimum calcification score. Another limitation too is that the regimen is kind of all over the place. Some are weight-based dosing, some are arbitrary, twice a week, 3 times a week, and short in duration. But all told, Wen and colleagues published a meta-analysis of these trials, and they found that there was a reduction in the progression of coronary artery calcification and iliac artery calcification with these surrogate measures. There's a reduction in pulse wave velocity increase. And so put another way, there's a reduction in progression of arterial stiffness. A main limitation of STS is GI side effects. So as a whole, 25% of people in these trials had GI side effects. And in one in particular, I think it's this 4th trial here by Seng Pennant, that 75% of people did not tolerate sodium thiosulfate and had to have it discontinued. So, I think whether or not to use sodium thiosulfate in people with just indiscriminate vascular calcification and dialysis is still kind of up in the air. So moving on to vitamin K. So there's at least two lines of reasoning why folks have studied vitamin K as a calcification inhibitor. So vitamin K is a cofactor for this matrix GLA protein. You may remember from that seesaw as a calcification inhibitor. And that studies have associated warfarin use with increased medial artery calcification and CKD. And vitamin K comes in two flavors. So there's two trials of vitamin K1. VitaVasc was an 18-month trial in dialysis. It was stopped early due to low recruitment. So their goal was actually over 300. They only got 60. What they found was that CAC progression was 68% lower in vitamin K1 versus standard of care, but this was not statistically significant. In a second trial, IPAC, similar duration and size, comparing vitamin K1 versus placebo, and similarly, there was not a significant reduction in CAC progression between the two groups. There are more studies of vitamin K2, and I'll specifically shout out the Valkyrie study, which is interesting. Valkyrie recruited people not only on dialysis, but all of them had AFib that met criteria for anticoagulation. And so in Valkyrie, the control group were patients on rivaroxaban only, and the intervention group was rivaroxaban plus vitamin K. But all told, all of these 5 studies here did not show any difference in these surrogate measures of vascular calcification between vitamin K2 and control. And so, you know, vitamin K would appear to be a bit of a dead end here too. Moving on to magnesium. So magnesium prevents vascular osteogenesis in vitro and in vivo. And there are observational studies associating higher magnesium with reduced vascular calcification. And so those are reasons why magnesium is studied. There are 3 trials of magnesium, 2 I'm showing here, 1 I'll show in the next slide. So Bressendorf, over a 28-day period, studied 59 patients on dialysis. And their outcome was this serum measure called serum calcification propensity, and compared patients with high mag versus low mag dialysate, so 2.0 versus 1.0, and they found that 2.0 was better. There was reduced serum calcification propensity. Sakaguchi and colleagues, this Japanese study, CKD 3-4 not on dialysis, and they compared daily oral elemental magnesium, and I think this was titrated to a serum mag somewhere between 2.5 and 3 compared with placebo. And they found that there were favorable effects with the magnesium. So lower coronary artery calcification progression compared with placebo, despite being stopped early due to high dropout. So 27% of people did have to drop out primarily due to diarrhea. So from these 2 studies, magnesium would seem to be pretty promising. Third existing trial, Magical CKD, which I think is an awesome study name. Also non-dialysis CKD, comparing daily oral magnesium versus placebo. This was a null study, so no difference in coronary artery calcification, but also stopped early for slow recruitment, and almost half of people at magnesium supplements had loose stools. There's also an ongoing study called DialMag. It's a Canadian study, very large, 25,000 people. And this is randomizing to high versus low magnesium dialysate, looking at hard clinical endpoints. So I think magnesium is pretty exciting. At NKC, we use 1.0 milliequivalent magnesium, so this could be a game changer. Their projected timeline on their website said that they'll collect all information by spring of 2026 and publish data in the fall of 2028. So a bit of time, but you know, this is pretty promising. And so now we kind of get into the alphabet soup investigational stuff. So SNF or SNF 472, real briefly, it's a calcification inhibitor that binds to the surface of hydroxyapatite crystals. The pathogenesis of vascular calcification is pretty complex, but the formation of these calcium phosphate crystals are kind of a collective last step. And so there are two studies. In the Calypso study, it's a 1-year study of patients on dialysis using this study drug versus placebo. There was a reduction in CAC score and aortic valve calcification. Calcifics, which I think is a pretty neat study, then recruited patients on dialysis with active calciphylaxis, which is also, obviously a consequence of vascular calcification. And they studied this drug over 12 weeks. And what I think is neat about this study is that, calciphylaxis, you can actually look at lesions and quantify if the wound is healing, pain has improved over in theory, a short period of time. What they found with this drug, though, is that there was no difference in this wound assessment tool or a pain visual analog scale between the study drug and placebo. And to my knowledge, there are no other ongoing trials of this drug. So I'm really unclear of where this stands, but it's kind of, these two studies are the only ones we have at this point. This is the last drug, INZ-701, and I can't talk about it without talking about pyrophosphate. So pyrophosphate is a calcification inhibitor. It's produced by arterial smooth muscle cells, and it blocks hydroxyapatite formation, almost similar to the previous drug. And the take-home message I want to share with you here is that pyrophosphate is reduced in kidney disease. So this calcification inhibitor is reduced. And that lower concentrations of pyrophosphate have been associated with greater calcification. So in this study, for example, you have quartiles of pyrophosphate here, and the higher the quartile of pyrophosphate, the lower your baseline calcification score measured using CT. This study also imaged the participants at 1 year, and they found similarly the change in calcification score decreased with increasing baseline pyrophosphate. And so INZ-701, it's an enzyme replacement therapy protein that regenerates pyrophosphate from ATP. And so far, we mainly have animal data. So this is a mouse study of an ectopic calcification mouse model, where this ABCC6 knockout mice are mice that are more likely they have this calcification disease. And so on biopsy, you can see wild type here on the top left. There's no calcification in the arteries. In the knockout mouse, you have significant calcification here in black. And the bottom two boxes here, when you treat with this study drug, INZ-702, two different concentrations that visually the calcifications seem to decrease. They also quantified the amount of calcium per gram of tissue here in panel B. And so wild type here in blue had the least amount of calcium per gram of tissue. Unsurprisingly, the knockout mouse that's not treated had the highest amount. And then when you treat with this investigational drug in the knockout mice, the calcifications by mass decrease. And so where we are now is that there is a phase 1 trial of this drug in humans called Seaport-1. And their endpoint is, to see if it raises plasma pyrophosphate without causing many major safety issues in dialysis. And so at Kidney Week, they published some interim data. It's a small N. I think their total N is just 11, but in 8 people over 28 days, what you can find is using this drug, I believe it's post-dialysis 3 times a week, you're able to raise pyrophosphate levels kind of in a linear fashion. And this is compared with 10 control subjects without kidney disease that showed baseline, at baseline your pyrophosphate levels are higher. And so that's kind of the whirlwind tour of trials of calcifications, past, present, future. Just some concluding remarks. So there are no treatments to date that have shown to actually reverse vascular calcification in CKD. And if that can be discovered, it would really be a game changer, not only in our population, but the general population too. There are no treatments, again, to date that have shown that reduce mortality and CV events via reducing vascular calcification progression in CKD. However, I really want to leave you with this, is that there are several ongoing clinical trials that really offer hope. And so what you all can do now, is continue treating CKD MBD per guidelines. But if there are opportunities to enroll patients in trials, I would encourage you to talk to your patients about it. And yeah, so I'd like to acknowledge my research mentoring team, especially my primary mentor, Ian DeBoer. And there were a couple individuals that I met at ASN that talked about vascular calcifications that indirectly had input on the slides here. Thanks for your attention.
Thank you so much, Simon. That was very informative. Great overview of kind of what the ongoing studies are out there and in this. And I think with that we can open for questions as well. I did see. Oh, sorry, Ian, please.
Thanks, Simon. This field has been around for a long time, but it's exciting to see how much is still ongoing and that there's still innovation here. And I'm just curious, which of these potential interventions or pathways you're most excited about? It's good to see multiple, but where would you like to see us move forward most aggressively?
Yeah, that's it's great. I think if you're talking about beneficial therapy, I think the magnesium one so far, most of the trials have been positive, so I think that's pretty promising. And my guess here with some of the other studies, so my PTH study and then phosphorus study, I think that there will be no difference in driving down PTH compared to letting the PTH rise, because the pathways, there's so many pathways and we're just choosing one. And similar with phosphorus, I think that that trial is likely to show that high versus low phosphorus, there will be no difference. And while that seems like kind of a bummer, I think that maybe if we take less emphasis off of those treatments, we can place more on things that we know to work, whether or not it's calcification related or not, and that can ultimately benefit patients too.
All right, thank you. Yuharn, you had a question?
Yeah. Hey, Simon, great talk. I have a slightly unfair question. What do you think happens to patients when their kidney function gets better? For example, a kidney transplant. Like we have a lot of patients, their kidney function gets better. In the CKD world, like there's all these talk about using non-calcium binders, and then we put them on calcium because they're going to be on, prednisone for life, and then it's better for their bone health. What happens to them after, like when the kidney function gets better?
It's a great question. I I don't think we know. I think the studies suggest that kind of in the short term, like months to maybe the first year after transplant, they're at higher risk for still for fractures and maybe cardiovascular events, but that things get better. So there are things happening at the tissue level that overall improve. But specifically how in the timeline, I think is not particularly clear. With regards to whether you should continue using those therapies, I think so. I think, I did a study in CRIC earlier this year, and one of the treatments that are associated with fractures is prednisone use. This was in non-transplant patients, but I think prednisone use is such a high risk factor that for fractures and required harms bone that I think you should still use calcium. And the rationale for that is to provide positive calcium balance for bone rather than, phos binding and stuff like that.
All right, very good. And then I did see, I just want to make sure, Nancy Columbong, I did see that you had your hand raised earlier. I just want to make sure you didn't still have a question or comment. Nope. Okay. All right. Well, if no other questions or comments, thank you for that, Simon. That was really informative.